For an ankle evaluation, initial things you're going to look for decap BTLS, deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, or swelling. No apparent decap BTLS. With the foot, just going to take a visual inspection. You should be able to notice any sort of oddities. Compare bilaterally, one foot and ankle to the other. If there's any malalignments or deformities or issues, they should be plainly visible. Next thing to test would be pulse motor sensory function of bilateral feet and ankles to make sure both sides are equally perfusing. Pulses are present. Can you wiggle your toes for me? Look over there. Can you tell me which toe I'm grabbing?
The one next to the pinky toe. One over, middle toe.
Close. Can you tell which toe I'm grabbing?
Pinky toe.
Alright. Bilateral sensation, motor function, pulse is present. I'm going to check dorsalis pedis pulses as well. Pulse is present. No issue there. Next you would check the bony anatomy. So you're starting with the distal tibia. You're going to palpate all of the distal shaft of the tibia, the medial malleolus. Palpate the distal femur, the lateral malleolus. You're going to palpate the calcaneus, the talus, and navicular. You want to palpate your cuboid, your first, second, and third cuneiform bones as well. You want to palpate your metatarsals. Palpate phalanges, so your metatarsophalangeal joint and your inner phalangeal joints as well. You only have an inner phalangeal with the hallux. With the rest of the toes, you have proximal and distal interphalangeal joints. You want to palpate each bone, each joint. After bony anatomy, you want to check musculotendinous anatomy. So with the superficial posterior compartment, you have the gastroc and the soleus. Deep to those, you have the flexor muscles of the foot and ankle. So the flexor hallucis and the flexor digitorum. The lateral compartment is going to be composed of the extensors, with your extensors responsible for digital extension and dorsiflexion. With your anterior compartment, you have muscles responsible for dorsiflexion as well. So you want to palpate all of your musculotendinous anatomy. So you're not going to be able to reach the deep posterior compartment, but you can get the superficial with the gastroc. Lateral compartment. Should be checking patient for any signs of pain or indications of point tenderness. Anterior compartment's going to run right along the tibial shaft. So then you're going to check your ligamentous anatomy. So that'll include your anterior talofibular ligament. So you want to find your talus and your fibula. So anterior talofibular ligament should be running right here. Your calcaneofibular ligament is going to run right about like that. your posterior talofibular ligament. It's going to run you're not really going to be able to get the posterior talofibular with the deltoid ligament. That's going to be on the medial aspect of the ankle, right along the medial malleolus. And then you have your anterior tibiofibular ligament. So that's also going to be on the medial side from the anterior tibiofibular ligament. That's going to be in the high ankle, connecting the tibia and the fibula. So, location of high ankle sprains. For dermatomes, so your L4 dermatome runs along the great toe and the medial lower leg. So right along here, you want to check for bilateral sensation of equal strength and intensity. For L5, that's going to be toes 2 through 4. 2 through 4 with the anterolateral leg. So bilateral sensation equal in intensity. Your S1 dermatome is going to run along your 5th toe and the posterolateral leg. Bilateral sensation of equal intensity. And then your S2 dermatome is going to be the heel and up the posterior aspect of each leg. Bilateral sensation of equal intensity. Another function you can check for nervous system intensity is Babinski's reflex to see if the toes curl when you scrape the underside of the foot right on the plantar surface. For range of motion testing, first you want to check active range of motion. So unassisted, you want to check patient's ability to plantar flex the foot. So can you flex your feet down for me? You want to measure range of motion, should be between 0 and 45 degrees from neutral. So from neutral to 45 is roughly here. You should observe for any differences in range of motion. Now flex your feet up for me. Dorsiflexion should be between 0 and 20 degrees from neutral. So measurement would be from here, roughly 20 degrees. For inversion, I want you to point both your feet in for me. You should have 0 to 20 degrees, roughly, range of motion. As long as bilateral flexion is demonstrated, there's no issues. For eversion, point both your feet out for me without rotating your legs if possible. Just point your feet. So eversion, between 0 and 10 degrees, range of motion. So with no indications of unilateral pain or lack of range of motion, patient presents no issues. Next thing you could test for is passive range of motion. If there is a unilateral finding, you could check for assisted range of motion. So if they're able to move both sides equally while assisted, that's a negative finding. There's no issues there. And then resistive range of motion. So press up against my hands, down, in, out. That's also a strength test. If there's diminished strength in one side or the other, you'd have a neuro issue going on. No findings with that. With your special tests, so you're going to, for anterior drawer, so you're checking the anterior talofibular ligament. So the talus to the fibula, right here, is what you'd be testing. And you stabilize the distal tibia and fibula. Try to pull forward. And hope this is testing the anterior talofibular ligament for laxity. The talar tilt, you're testing the calcaneofibular ligament. So it'll be running right here. This one. Stabilize the distal tibia and fibula again. You're tilting the talus. Also testing for laxity of the ligament. Deltoid stress test. You would be testing the deltoid ligaments of the medial aspect of the foot. So, from same position, stabilize the distal tibia and fibula. You want to stress the deltoid ligament. So an eversion to stress the deltoid ligament here. Testing laxity there. Thompson test, you'd have the patient roll over into a prone position. Thompson test, you're testing for whether the Achilles tendon is intact and working efficiently. You should see motion in the foot when you compress the gastrocnemius.